Thank you, Ward, and thank you all for joining us today for our webinar on tobacco use among the homeless population. I'm Kerry, Cork, a senior staff attorney at the Public Health Law Center and Tobacco Control Legal Consortium. We have 3 speakers and a lot to cover today, so I'm going to keep my opening remarks brief. Okay, I'd like to start by saying that this webinar is sponsored by the Public Health Law Center's Tobacco Control Legal Consortium, our national network of legal centers and attorneys that support tobacco control policy change at the local, state, and national levels. We do this by providing free legal technical assistance to tobacco control advocates, public health professionals, local and state health departments, coalitions, government, and private attorneys and individuals. For more information about our organization, please visit our website at www.publichealthlawcenter.org. Okay, as I mentioned, I'm Kerry. Part of my job at the Public Health Law Center and the consortium is to provide legal technical assistance on tobacco-related issues around the U.S. I'll be moderating and also presenting today. We're delighted to have as our next featured speaker, Dr. Vijayaraghavan, who is a practicing general internist at the San Francisco General Hospital and an assistant professor in residence at the Department of Medicine at the University of California, San Francisco. She's also a researcher in tobacco control with a focus on vulnerable populations, particularly individuals experiencing homelessness. Maya's intervention research stems from collaborations with community organizations. She received her MD from Boston University School of Medicine, a Master of Advanced Study degree from UCSF, and a postdoctoral fellowship from the University of California, San Diego. Maya is going to speak on several of the studies she's conducted related to tobacco use in homeless shelters over the last few years. Finally, my colleague, Darlene Wong, will speak. Darlene is a staff attorney with the Public Health Law Center who provides legal technical assistance on tobacco control issues to public health professionals and organizations, legal professionals, and advocates in Minnesota and throughout the U.S. Darlene has both a law degree and a master's in public health. Before joining the Public Health Law Center, Darlene served as an Institute of Medicine Tobacco Regulatory Science Fellow at the U.S. Food and Drug Administration. She's also worked at state and local levels in tobacco control, both in Minnesota and Colorado. Darlene is going to speak about a sticky issue regarding the intersection of smoke-free policy, fair housing, and disability law. Many formerly homeless individuals reside in public housing. Many public housing residents are disabled, and 1/3 of these tenants smoke. Okay, so with that, let's get started. I'm going to begin by giving you a brief overview of a very big and complicated problem. And although we'll talk at the end about a few possible policy options, what we really hope to do is help advance a much larger discussion about what we can do at the local, state, and national levels to address the problem of tobacco addiction in the U.S. homeless population. Yes, folks who find themselves homeless generally are struggling with a host of problems, and believe me, tobacco use is not on the top of the list. But when you realize that nearly 3/4 of homeless adults smoke cigarettes, a prevalence 4 times that, of the U.S. adult population, and when you realize what a toll tobacco use takes on the lives of these vulnerable individuals, I think you'll agree on the significance of the problem. Last year, the American Cancer Society asked the consortium to conduct a preliminary study of how tobacco use and secondhand smoke exposure is addressed in the majority of homeless shelters and similar programs throughout the U.S. Today, I'm going to report on our findings by talking briefly about the face of the homeless in the U.S. today, the patterns of tobacco use, barriers to tobacco cessation, and policy options and promising interventions for people in this population who are addicted to nicotine. So let's take a quick look here at what we mean when we talk about the homeless population. We all probably have different images in our mind when we think of homeless individuals, including the folks you see on the street But defining homelessness is actually fairly complicated. It's not just a state of being without a home. It's also been described as a state of abject poverty, often accompanied by high-risk comorbidities. Different government agencies, like the Department of Health and Human Services and the Department of Housing and Urban Development, use different definitions of homelessness. This, of course, affects how various programs determine eligibility for individuals and families at the state and local levels. Here's a working definition of homelessness used by the Homeless Emergency Assistance and Rapid Transition to Housing Act of 2009. This is a definition that many programs funded by HUD use. As you can see, it covers individuals and families who don't have fixed, regular, and adequate nighttime residence, who are at imminent risk of losing their main nighttime residence. It also includes unaccompanied youth, families with children, and individuals and families who are fleeing or attempting to flee life-threatening conditions. Also, as you know, there are different types of homelessness. They're the chronically homeless, which are more like the stereotypical profile of the person on Skid Row, living on the street or under a freeway overpass. These people are likely to be older than other homeless folks and may be the hard term unemployed, often suffering from disabilities and substance use. They often tend to use shelters as long-term housing rather than an emergency situation. Then there are the episodically homeless, who tend to shuttle in and out of homelessness in institutions that house them. These individuals are more likely to be young, chronically unemployed, and often experience medical, mental health, and substance use problems. They often spend periods in and out of hospitals, jails, detox centers, or the streets, and only use the shelters occasionally. And finally, there are the transitionally homeless, who typically enter the shelter system once or twice and for only a short period after some catastrophic event, such as unemployment, bankruptcy, divorce, eviction, and so on, and they're forced to spend just a short time in a homeless shelter before transitioning into a more stable housing arrangement. The transient lifestyle of many homeless individuals makes it challenging to get a clear estimate of the homeless population in the U.S. and a demographic breakdown. Estimates of homelessness range from 578,000 to 750,000 on any given night, and up to 2 to 3.5 million in any given year. What's more, there's no one face of the homeless. The panhandler standing at the intersection with the cardboard sign may be the person we think of when we think of the homeless, but those suffering from homelessness include a vast array of individuals. Although the median age of the homeless in the U.S. is 50 years old, a good percentage of those in shelters and transitional housing are youth and children. Individuals experiencing homelessness typically cope with a host of challenges. For example, 20 to 30% of homeless adults have a serious mental illness, and roughly 30 to 50% suffer from either substance use or dual mental illness and substance use disorders, such as alcoholism or illicit drug use. They're likely struggling with the stress of needing to feed themselves and their families with little or no access to medical care or a social support network. So you add to all these challenges the startling statistic that 3 out of all 4 homeless people smoke, which, as I said earlier, is approximately 4 times the rate of the general population. Homeless people are 2 to 4 to 5 times more likely to die prematurely. Some studies estimate that the average life expectancy of the chronically homeless adult is 41 years. The list of problems just goes on. Many homeless individuals suffer from medical issues, which are often untreated. In fact, cardiovascular disease is the primary killer of homeless and formerly homeless individuals. Obstructive lung disease is more than twice as high in homeless individuals as in the general population. They're susceptible to a range of chronic and infectious diseases and common health concerns, including HIV, diabetes, hepatitis C, tuberculosis, and of course are at an increased risk for cancer. Just as an aside, poor health is often a major cause of homelessness. And there are other problems too. These people may find themselves unable to get a job due to cognitive deficiencies, illiteracy, limited skills or education, an existing criminal record, precarious immigration status. They also may be displaced because of changes in the housing market, as I mentioned before, the eviction, foreclosure, bankruptcy, and they may be struggling with skyrocketing rent, physical trauma experienced in childhood, any number of challenges. Because of lack of resources, low-income and homeless smokers often use tobacco in unconventional ways, ways that increase the likelihood of ingesting infectious agents and toxins trapped in filters and tobacco remains. For example, they often snipe, which involves digging around in the trash or searching the ground for discarded cigarette butts or filters with enough unsmoked tobacco in them to warrant the time it takes to find, unravel, or re-roll them. As a result, homeless smokers and smokers in general often suffer from gum diseases such as gingivitis and periodontitis. Untreated, these conditions can lead to pain, tooth loss, and other health problems. So what are some of the obstacles state and local communities and healthcare providers face in addressing this problem? Well, it's hard for many smokers experiencing homelessness to quit. Many of those with mental illness and substance use disorders are 2 to 4 times more likely to smoke, and have fewer quit attempts and more relapses. They often use tobacco in combination with alcohol or drugs, or as a way to achieve a nicotine buzz or a substance high. Also, smoking is seen as a way to cope with the stress, boredom, and tension of living in survival mode day after day. It's a way for many to self-medicate, socialize, retain some measure of control over their lives, and reward themselves in the short term. Many of these people, particularly the chronically homeless, are severely depressed, and they don't hold out a lot of hope for the future, so immediate gratification takes precedence over long-term health effects. Dr. Travis Baggett, national authority on this topic, put it eloquently, I think, when he described tobacco use by homeless individuals as, quote, an expression of autonomy in the face of desperation and a source of comfort in the midst of chaos. Also, there's no question but that the tobacco industry has traditionally targeted low-income smokers with its predatory marketing schemes, pricing discounts, and giveaways, and makes it easy for them to continue to access low-cost tobacco alternatives, such as cigarette-like cigars. For example, in 1995, R.J. Reynolds launched its Project SCUM, that stands for Subculture Urban Marketing Plan, to target vulnerable groups in San Francisco, including street people in the Tenderloin. And yet, despite all the personal, psychological, environmental, and systemic barriers, a majority of the homeless smokers in a wide number of studies insist they want to quit and are motivated to quit, and they try repeatedly to quit. The problem is, how can local and state providers, including clinical behavioral health and tobacco cessation public health professionals, give them the help they need? And this is a tough one. So here's a look at some of the housing providers that work most directly with the homeless. Each of these types of shelters transitional housing has funding and resource challenges and may be organized or administered differently. And this all may have implications for their capacity to provide tobacco cessation services. Shelters, halfway houses, and other housing providers face a lot of challenges, often just keeping their doors open. In addition, homeless service providers have traditionally used cigarettes to build trust among their homeless clientele. Figures vary, but and I've interviewed several experts in the field, and I've heard fairly consistent reports that up to 1/3 of the staff in these programs tend to smoke. What's more, there's still a triage mentality that nicotine addiction is less a priority than addressing other behavioral health and substance abuse issues, and that tobacco cessation treatment could dangerously interfere with other medical treatments and could jeopardize or compromise recovery or stability. Well, actually, smoking can complicate the treatment of patients with mental illness. Data suggests that smoking cessation can help reduce mood and anxiety disorders and depression. Around the U.S., there continues to be a need for coordination among service providers, particularly those working with individuals experiencing homelessness, such as social services, primary care, mental health, substance use, and tobacco addiction specialists. Also, homeless service providers are generally short of funds for bare necessities, let alone funding for NRT products and trained counselors or cessation programs. Some of them are simply not set up to provide on-site cessation services or support. Moreover, this is a transient population that may not have ready access to cell phones for quit lines or the ability to travel to cessation counseling sessions. Finally, and this is a big problem, there are a lot of different subgroups that make up the homeless population. There's a wealth of studies out there identifying the different problems of the homeless population and the pervasiveness of tobacco use in this group, but work still needs to be done on the most effective ways to address smoking in each of the different subgroups. For example, the homeless vets, the mentally ill, youth, families with children, substance users, the runaways. The problem is it's often not easy to recruit or retain homeless individuals in cessation trials, and Maya is going to address this more in her presentation. So let's look at a few policy options. Tobacco-free environments denormalize smoking and promote cessation. Most homeless shelters are smoke-free on the premises, and many prohibit smoking on the grounds. Some studies of tobacco use in homeless shelters, though, have found that lack of knowledge among staff about nicotine addiction, negative staff attitudes toward the smoke-free policy, and staff smoking pose significant barriers to establishing a smoke-free culture in the shelters. And as I mentioned before, some staff continue to smoke with clients, which is a problem not restricted to homeless populations, but is common in other settings as well. To address that, and to help defeat the cultural norm of smoking in shelters, it's important to train staff on the public health rationale of quitting and make it a priority for employees to walk the talk and not smoke. Some communities have found that peer-driven models are effective in tobacco cessation. In addition to involving staff who were former smokers, providers could consider retaining formerly homeless clients and advocates to work at the shelter as peer advisors. Penalties for violating a shelter's tobacco policy should be enforced fairly and consistently and be sufficiently severe to discourage attempts at circumvention by other residents, including staff. Shelters should make every effort to prevent the use and trafficking of tobacco contraband by visitors. Also, be sure to work with community and social service organizations, faith-based organizations, and primary care, behavioral health, and other groups to reach members of the homeless population with tobacco cessation assistance, along with other public health services. And here are just a few examples of ways that communities in Arizona, Alaska, and Minnesota reach out to this population. So Maya is going to discuss this in more detail, so I'm just going to make one quick point here, that researchers are often challenged in identifying effective interventions for the homeless population because of the difficulty in recruiting and retaining smokers in studies when they have no permanent address, they're often hard to reach, and when they may be suffering from mental illness, cognitive impairment, or substance abuse. And so many are screened out for various reasons. So this is just an example of some of the incentives that were found to be effective in some studies. Several studies have also highlighted the cessation treatment preferences of some subgroups of homeless smokers. Making nicotine replacement therapy available in shelters may help reduce craving at night in smoke-free settings, and many clients express preference for short one-on-one counseling sessions. And some clients have expressed concern about losing or having their NRT products stolen or misplaced. If at all possible, shelters should make tobacco dependence information and resources available along with quit line information and access to these NRT products. And finally, though I've talked primarily about what housing providers can do to address this problem, this is not a problem that providers can address without the support and collaboration of other stakeholders in the community. Social service workers, primary care, behavioral health, and addiction experts, and policymakers all need to work together to address nicotine addiction among the homeless at a variety of different levels and through different means and agencies. Looking ahead, we see promising opportunities to address this problem. Many formerly homeless individuals and families, as well as folks who require supportive or assisted living services and may be struggling with behavioral health issues or physical disabilities, reside in affordable or public housing. And Darlene is going to talk a little bit more about the HUD smoke-free rule and how that affects formerly homeless tenants and disabled individuals. There are also popular programs such as Housing First that are beginning to encourage the integration of tobacco cessation services with other services provided to individuals as soon as they've received some type of housing. Finally, the consortium summarized our American Cancer Society funded research in 2 recent publications, a white paper, Underserved and Overlooked, and a fact sheet of frequently asked questions on tobacco nicotine addiction within the homeless population, both of which are available for free on our website, www.publichealthlawcenter.org. So with that, I'm now going to turn things over to Dr. Maya. Maya?
Thank you. Thank you, Kerry. So I'm going to start by first talking a little bit about the epidemiology of non-cigarette tobacco and nicotine product use among homeless adults and youth. And this topic is of particular salience these days with the rise in the use of these products, and recent studies have actually documented that use of these products have been increasing in the homeless population as well. So first, among adults, I'm going to talk about 2 studies, one that was done in Dallas, Texas by some of my colleagues and focused on a sample of sheltered homeless English-speaking current smokers. These data were collected in 2013, and they looked at use of non-cigarette tobacco in the past month. And what they found was among the cigarette smokers, about half had used some form of other tobacco or nicotine product in the past month. The most common ones that they found in this study were the use of little cigars and roll your own tobacco, with e-cigarettes comprising a smaller proportion of users. In another study by Dr. Travis Baguette, who was referenced earlier in Kerry's presentation, focused on a sample of homeless English-speaking current smokers in Boston. These data were collected in 2014, and what they found was that 68% had used another tobacco product or e-cigarettes in the past month. And again, the most common forms of other tobacco were little cigars and cigars, with a slightly lower percentage of people using e-cigarettes and a much lower percentage using smokeless tobacco. The reasons for e-cigarette use has been described in a few studies, both quantitatively and qualitatively. And some of the reasons are very similar to what's been observed in the general population. Individuals have perceived these products to be less harmful than cigarettes. Some of them report using e-cigarettes to either cut down or quit cigarette smoking, and they have found that persons who were more ready to quit also were more likely to use e-cigarettes. Some of the other reasons was curiosity, the flavors or novelty of these products, and a big reason was to circumvent indoor smoking restrictions. Two studies have looked at what are the factors associated with dual and poly use of tobacco. And when I talk about dual and poly use, these are current smokers who are also using one other or multiple tobacco and nicotine products. And what they found was that persons who were more likely to use other tobacco were people who had increased subsistence difficulties, so more financial need. And this is in part because little cigars and cigars tend to be cheaper than cigarettes, in part because of a tax loophole that allow little cigars to not be taxed the same way as cigarettes are. Persons who are dual and poly users also were more likely to have increased psychiatric symptom severity, and they were also more likely to have increased drug use symptom severity. So what is the pattern of use among homeless youth? So a study, again, that was done in Los Angeles among 292 community-recruited sample of homeless ever cigarette smokers. These data were collected in 2014. They again found a high proportion of homeless youth who had used some other form of tobacco in the past 30 days. In this study, about 72% reported that they had used another form of tobacco in the past 30 days. You can see that the proportion of use, or the profile of the use of tobacco products, are slightly different, with e-cigarettes being the most common form in youth, followed by little cigars, hookahs, other smokeless tobacco, and chewing tobacco. This study found that e-cigarette use was more common among those who slept outdoors compared to those who were sheltered. Chewing tobacco or snuff was more common among males, and little cigars was more common among African Americans. So what are the reasons for e-cigarette use among homeless youth? So among the 83 youth current smokers who had ever tried an e-cigarette, about half had viewed e-cigarettes to be less harmful. And the most common reasons for use were, again, to avoid having to go out to smoke or to deal with situations or places when I cannot smoke. So what is the implication of non-cigarette tobacco and nicotine products use in homeless populations? I bring this up before we talk about interventions for tobacco use, only because I think it's going to play a role in how we address tobacco use in homeless populations. So one, the dual or the concurrent use of cigarettes with other tobacco and nicotine products suggests potentially increased nicotine dependence, which poses challenges with tobacco cessation. Indeed, persons who may be using e-cigarettes to quit cigarette smoking may also be the people who are struggling with cigarette smoking cessation for any number of reasons, and this is compounded on the fact that that these people are experiencing all the challenges with homelessness that can pose difficulties with smoking cessation. Taken together, these results suggest that treatment programs for tobacco should also include assessment of non-cigarette tobacco and nicotine products. They should educate about the harms of dual and poly tobacco use, and that that we should capitalize on interest in quitting, but direct this interest toward approved medications for cessation instead of e-cigarettes until there's further evidence. So I'm going to focus on interventions and policies for tobacco use. So the first section is tobacco cessation trials, and I'm going to describe both challenges and results. So tobacco dependence treatment, as Kerry mentioned, includes smoking cessation counseling, pharmacotherapy, including nicotine replacement therapy, Wellbutrin and varenicline, and combined counseling and pharmacotherapy has been shown to be more effective than either alone. So there have been 6 studies that have demonstrated the feasibility of engaging homeless adults in cessation trials, and 2 clinical trials are in progress. As Kerry mentioned, recruitment and retention has posed barriers to conducting studies or research studies with this population, but in recent studies, it looks like retention rates have actually been really good. So I'm going to focus a little bit on barriers to retention, which includes substance use, being a male, irregular use of health services, poor physical and mental health, and high stress. These are some of the factors that have been found to limit recruitment and retention into cessation trials. Some of the factors that have been associated with increased retention in a large randomized controlled trial of homeless adults for smoking cessation, and I'm going to discuss this trial in a little bit, but factors that were associated with increased enrollment was older age, having healthcare coverage, having a lower stress level, and having a history of multiple homeless episodes. And the thought was that people who had been homeless multiple times may have already experienced may have already had the experience of having to keep appointments. So we're able to follow up a lot more easily than those who had been homeless only once in the past. And as has been shown in other studies, alcohol and substance use was associated with decreased retention. So as I had mentioned, recent studies have demonstrated retention rates of around 75% to 80% up until the end of the study. And for many of these studies, it included last follow-up visits at 6 months. And some of the features of these studies that made retention possible was to conduct study visits at community-based sites. So if the study was done at a homeless shelter, then localizing study visits at the site rather than having people to travel was one of the successful features. Having a flexible visit schedule, using community mobilizers or peer researchers, and I'm going to talk about this a little bit in another study that utilized this approach and was highly successful in both recruiting and retaining participants in a smoking cessation study. Asking for multiple forms of contact, including places that participants spend time, scheduling weekly or monthly check-in visits, and incentivizing visits, and Kerry alluded to this in her slide, either providing gift cards or transportation, hygiene kits, cash vouchers, not only for completing survey instruments or interviews, but also for attending study visits. So I'm going to talk about one model that has been successful in engaging study participants, and this is called the Participatory Research in Ottawa Management and Point of Care of Tobacco. It's the PROMPT study, which utilized a community peer model. This study was conducted by one of my colleagues in Ottawa, and they capitalized on social networks within homeless communities. And what they did was they partnered with one of the largest homeless shelter in Ottawa, and they designed a 10-step Ottawa citizen engagement and action model. And I'm highlighting some of the elements of the 10 steps here in this slide. So they basically trained peers who were selected from the target population. So these are individuals who either use services at the shelter or had been previously homeless or currently homeless. And they trained these peers to conduct all aspects of the study in a true community participatory-based research model approach. So the peers identified that tobacco use was the most pressing concern. So they formulated a study question around tobacco use. They were involved in designing the study, including the study design, as well as provided input on the study instruments. They participated and conducted all the recruitment and consenting. They administered the questionnaires. They conducted all the follow-ups. They were involved with interpreting the findings and also disseminating the findings. And for these efforts, they were provided an honorarium of around $15 an hour for every hour they spent on the project in conducting any of the study procedures. So this model was highly successful in engaging both peer researchers, which is what they call them, or community researchers, as well as in engaging participants in the study. And in this case, a nurse provided counseling and nicotine replacement therapy to clients in the homeless shelter. But what the peers were able to do is provide, the peers were able to support this intervention by providing additional workshops, life skills, money management, on-the-cusp conversations with participants in the study. So the results, the actual smoking cessation results for the study are pending, but the trial is complete and we should be seeing them in the near future. So I'm going to talk for the next few minutes on quit rates from current cessation trials and interventions, and I'm going to try and highlight key elements from each of these trials. So the first was conducted in 2006 by Dr. Okuyemi, and this was an uncontrolled trial, but participants were randomized to 2 counseling conditions. One was a motivational interviewing that was focused solely on tobacco use, and the other was a motivational interviewing session that included tobacco with other substance use. All the participants received 6 weeks of group counseling with 8 weeks of NRT. There were 46 participants in this study, and they measured carbon monoxide, which is a biochemical measure of smoking cessation. Carbon monoxide verified 7-day point prevalence abstinence. So at 8 weeks, what they saw was that the group that received the motivational interviewing sessions that were targeted to both smoking and other substance use had a slightly higher abstinence rate of 17% compared to 13%. However, the results were not statistically significant. Similarly, at 26 weeks, the rate of abstinence at the group that received the more intensive motivational interviewing sessions were 17% compared to 8%. The next study was conducted by Dr. Shelley. It was uncontrolled, and the components of the intervention included 12 weeks of group counseling, nicotine replacement therapy, and bupropion. They enrolled 58 participants into the study. This was conducted in 2 homeless shelters. They looked at carbon monoxide verified 7-day point prevalence abstinence, and at 12 weeks they found a prevalence rate of around 15%, and at 24 weeks they found a prevalence of around 13%. The third study, again conducted by Dr. Okuyemi, is a pretty impressive study for what it achieved. It enrolled 430 homeless adults in a 2-group randomized control trial. It's the largest randomized control smoking cessation trial in the homeless population. The components of the intervention included 6 weeks of individual motivational interviewing with 8 weeks of NRT, compared with usual care, which was one session of brief advice to quit. And what they found was that the rate of abstinence was higher in the group, in the intervention group, at 9.3% compared to 5.6% in the usual care group, but this was, again, not statistically significant. Another trial by Dr. Sagan looked at 12 weeks of a nurse-led counseling intervention with medications and a referral to a quit line, and found quit rates of around 6% and 4% at 12 and 24 weeks. So up until then, the cessation trials included what was state-of-the-art and standard of care for smoking cessation, which is behavioral counseling and pharmacotherapy. The last two trials that I'm going to talk about that are on this slide are ones that were conducted by Dr. Boussinel and Dr. Carpenter. And what these trials included, in addition to behavioral counseling and pharmacotherapy, was contingency management or financial rewards for smoking cessation. And these trials are unique in that they were able to offer this additional intervention component to homeless adults engaged in cessation. The sample sizes for those who were offered these interventions are small. So it was 10 for the Boussinel trial and 20 for the Carpenter trial. The quit rates actually are quite impressive. So at 4 weeks, those who received financial rewards for smoking cessation had a quit rate of around 50% compared to 19% for those who didn't. And this effect was sustainable over time, at least for 8 weeks, where quit rate was 30% compared to 1.7%. There is one other study that is in progress, and this is by Dr. Rash, which again utilized contingency management or financial rewards for smoking cessation. And participants in this study, slightly higher number of participants, 70 participants. These participants received twice weekly counseling, nicotine replacement therapy, and contingency management. They also looked at carbon monoxide verified 7-day point prevalence abstinence. Now, this study was just finished, so the results are not out yet, but these are preliminary data from Dr. Rash that I'm sharing with you. Although they found no differences in point prevalence abstinence, they did find that persons who received contingency management had a longer duration of abstinence compared to those who did not. So they were able to turn in 17.5 consecutive carbon monoxide negative samples compared to 6.3 negative samples in the usual care group. So these trials definitely highlight the feasibility of engaging homeless adults in smoking cessation. They also highlight some promising approaches that can serve as models for interventions that could be integrated into service settings that are serving the homeless population. And just to look at quit rates and how it compares with other high-risk populations. So if you look at psychiatric inpatients, those who are offered behavioral counseling and pharmacotherapy, the quit rates at around 26 weeks is 16%. Psychiatric outpatients, the quit rate is around 18%. Female prisoners at 24 to 26 weeks, the quit rate is around 14%. Now, focusing on the largest randomized control trial by Dr. Okuyemi, the quit rate was around 9%, which is not that much lower than what we're seeing in other high-risk populations. So I wanted to then focus a little bit, provide a little bit more detail on one of the trials that offered incentives for smoking cessation and what made this trial, what were some of the features of this trial that made it successful. So Dr. Boussinel and his colleagues conducted this trial with homeless adults in shelters who were engaged in smoking cessation counseling and nicotine replacement therapy within their shelter-based program. They offered 10 participants additional incentives, and these were offered in so that they would increase incrementally depending on how long people were able to be abstinent. So they offered a $20 gift card for the first quit attempt, and were able to increase the incentive amount each week by $5 if they were able to be abstinent consecutively. So people had the ability to earn up to $150 for 5 weeks. And if they were unable to, if they relapsed in between, then the incentive amount was set back to $20. And while this study is promising, as are others that use incentives as a method to encourage cessation, larger and longer studies are needed to ensure that these effects are sustainable after the removal of incentives. So what are some of the cessation trials in the horizon? So Dr. Okuyemi has another study that is ongoing. This is a treatment of tobacco and alcohol dependence in the homeless population. This is a large trial of 645 participants. Participants are randomized to 3 conditions, including intensive smoking plus alcohol intervention using cognitive behavioral therapy, intensive smoking cessation intervention alone, 12 weeks of NRT, and then participants are going to receive 3 months of counseling with an additional 3 months of group counseling. So pretty robust intervention. And this trial is ongoing, so the results should be out as soon as the trial is done. So what about tobacco cessation capacity building interventions in homeless shelters? So as Kerry had mentioned, there's really little data on the provision of cessation services in shelters. We did a study in San Diego with 12 emergency and 40 transitional shelters and found that about 1/3 had offered on-site resources for cessation, either in the form of smoking cessation classes or a wellness initiative or a public health nurse. Another study that focused on 23 shelters and day centers serving homeless youth found that the majority did not provide on-site cessation services. There are many barriers to providing services, of which lack of resources was one of the barriers that was cited in our study, both in terms of money and staff to enforce smoke-free policies and implement cessation programs. Staff training and staff smoking were some of the other reported barriers. And perceptions among staff that smoking cessation is not a priority among clients is another barrier to addressing tobacco use in shelters. So we used the results and provided some pointers towards, provided a summary of recommendations to shelters to incorporate smoking cessation counseling and smoke-free policies within shelters. And some of these recommendations included restricting smoking outdoors to designated smoking zones at least 25 feet away, having separate smoking zones for staff and clients, considering broader restrictions on outdoor smoking in the property. And in terms of implementing smoking cessation programs, we thought that training that modified beliefs and attitudes among staff on the importance of addressing nicotine addiction was important. Training that improved knowledge among staff on clients' interest in smoking cessation, discouraging staff smoking with clients, training staff to provide brief cessation counseling, incentivizing staff to participate in cessation training, and partnering with local tobacco control organizations to increase capacity to provide cessation services were some of the recommendations that we and others have made in thinking about smoking cessation programs in shelters. So using these recommendations, we actually did a pilot study where we developed a capacity building intervention that included incentivizing staff to attend a brief training to provide cessation counseling, and also conducting the training over time so that participants were able to troubleshoot and problem solve it in terms of how to engage homeless clients in these conversations. So we trained shelter staff to provide brief cessation counseling. We pilot tested this intervention in 2 transitional homeless shelters in San Diego. And we looked at the provision and receipt of cessation services among staff and clients. And what we found that over a 12-week period, staff knowledge and staff efficacy in providing brief cessation counseling increased. Although client knowledge and attitudes didn't change, clients did report that they received more program-related content for smoking cessation post-intervention compared to pre-intervention. So I'm now going to switch gears and talk about smoke-free policies, which again Kerry alluded to in her slides. This is an evolving field with the earliest study that was done in 2007. There are no national data on the topic, but what we do know about smoke-free policies come from studies that were done in California and Texas. And these studies found that most shelters restrict smoking indoors, but they differ in outdoor restrictions on smoking, with some having campus-wide bans, others having no outdoor restrictions. They also found that most adults are supportive of these policies. So in the 2 studies that were focused in San Diego, we found that smoke-free policies were associated with anti-tobacco norms. That is, clients who were staying in shelters with indoor and outdoor smoke-free policies were less likely to smoke with staff compared to clients who were staying in shelters only with indoor smoking restrictions. We also found that smoke-free policies were associated with self-reported decreases in consumption, interest in short-term quit attempts, and interest in smoking cessation. Only a minority expressed interest in leaving the facility because of smoke-free policies. In relation to smoke-free policies in public housing, the idea is that this would improve the health of very low-income tenants by reducing secondhand smoke exposure. It could reduce tobacco use among very low-income smokers if policies are also combined with treatment. It has the potential to save over $15 million per year in maintenance costs and over $500 million per year in healthcare costs. However, there are some repercussions for not-for-profit supportive housing for homeless adults, and this HUD rule does not apply to these not-for-profit supportive housing for formerly homeless adults, unless housing is located in a city that has a local ban on smoking in multi-unit housing. So just to backtrack a little bit, supportive housing is the preferred method to end chronic homelessness. It offers housing with supportive services in a voluntary nature for people who've experienced chronic homelessness, who have mental illness, substance use, or disabilities. It's a highly successful program and has been found to reduce rates of utilization of both the hospital and other institutional settings, and also improve quality of life in the short term. We have a study that's ongoing right now looking at smoke-free policies in supportive housing in the San Francisco Bay Area, and what we found is that in most housing, smoking is not allowed in shared common areas that are indoors, but smoking is allowed indoors in living units. Implementing and enforcing smoke-free policies in supportive housing could potentially improve the health and well-being of residents and staff if it was implemented and enforced, but it could also be perceived as contradicting the harm reduction framework of supportive housing, where the priority is maintaining housing without any requirements that residents refrain or abstain from substance use or tobacco use. Overly aggressive enforcement could potentially lead to the loss of housing, which would be antithetical to what supportive housing is all about. but lack of enforcement could also dilute the positive effects of a policy. So some of our recommendations for implementing smoke-free policies in supportive housing have a lot to do with policies that need to be aligned with the goal of ending homelessness. So some of these strategies may include obtaining buy-in from residents and staff. These policies need to be designed with feedback from residents. They might include supporting the voluntary adoption of smoke-free homes prior to turning it into a building-wide policy. They should include ensuring either on-site cessation support in terms of counseling and medications, partnering with public health and healthcare facilities to increase resources for cessation,
Sorry,
I think I am. I'm sorry. I think I just lost internet connection in this room.
Oh, yes, so it does look like you are disconnected.
So let me try and log on again.
Alternately, if you tell me what slide you are on, I can just take over. You can keep presenting through the phone, and I can move your slides for you.
So, yeah, that would be great. So I am on slide. So I'm on slide, the possible strategies for implementing smoke-free policies in supportive housing.
Okay, we got you. Just give me a verbal cue every time you want to advance.
Sure. Okay, so sorry about that. So partnering with public health and healthcare facilities to increase resources for cessation, providing accommodations to make it easy for residents with significant disabilities to follow these policies, and having some sort of a staged enforcement that is not overly punitive. So the last kind of intervention that I wanted to focus on was media campaign. We actually, as you know, graphic warning labels are not approved by the FDA in the U.S., but these labels are approved in other countries. But what we do have are public health campaigns, including campaigns like the CDC Tips from Former Smokers, that have been found to be useful in conveying the harms or risks of tobacco products to individuals. What data suggests are that these labels help raise awareness about harms of tobacco, or these campaigns as well. They may also motivate cessation behaviors. So what we did in our study among older homeless adults was present some of these labels and ask participants to report what they felt after seeing these labels. And what we found was that participants were actually moved by seeing these labels. We presented primarily labels that showed the negative effects of tobacco use, and they found that they could be useful adjuncts to motivate cessation behaviors in combination with behavioral counseling and pharmacotherapy. And this is something that hasn't been explored in detail in this population, but another promising avenue for intervention. Next slide. So in summary, we found the data suggests that it is feasible to engage homeless adults in cessation. It is important to integrate counseling and pharmacotherapy into other services, and incentivizing cessation efforts may be a promising tool. Policy-level interventions are critical to reducing tobacco use, including smoke-free policies and smoke-free home interventions in shelters and supportive housing. Policies that mandate the provision of cessation services in homeless service settings, Media can potentially motivate cessation behaviors among certain homeless populations, and messages around tobacco need to be tailored to the unique circumstances of homeless adults and youth. So next slide. So current thinking in tobacco dependence treatment has focused primarily on the homeless population as a homogeneous population. Interventions have looked at behavioral counseling and pharmacotherapy, which is the mainstay, and will be seen as marginal reductions in tobacco use. Next slide. But as Kerry alluded to in her slides, the homeless population is a diverse population. It includes people who are sheltered or unsheltered. It includes people with mental health and substance use disorders. Includes people who self-identify as LGBT youth, older homeless adults, racial ethnic minorities, veterans. And our interventions need to provide behavioral counseling and pharmacotherapy and access to smoke-free policies, but they may also require additional adjuncts that need to be tailored to the unique needs of these subpopulations. And having a multimodal intervention framework might be helpful in promoting health equity by reducing tobacco use, morbidity and mortality, and tobacco-related disparities in populations experiencing homelessness. So there are many unanswered questions. Some of them include what interventions would benefit homeless subpopulations, what interventions would benefit homeless youth, what are the kinds of interventions that would lead to improved quit rates, what are some of the ways to increase smoke-free environments, and what are some of the ways to eliminate early childhood exposure to tobacco and nicotine products. And as we are trying to develop answers to these questions, some of my take-home messages today will be to ask everyone about cigarette and non-cigarette tobacco use, advise to quit tobacco use, provide access to or refer to cessation services, ask about e-cigarette and marijuana use and counsel against use, integrate counseling for substance use with counseling for tobacco use, ask everyone about exposure to secondhand smoke, and support interventions to increase access to tobacco-free housing and homeless service settings, and implementing policies to increase delivery of cessation services. And with that, I'd like to stop.
All right. Thanks, Maya, and to Kerry also for providing a lot of really rich information for all of us. We're now going to transition a bit and talk briefly about smoke-free policy implementation and enforcement. More specifically, I'll talk about these issues in the context of the U.S. Department of Housing and Urban Development, or HUD's, smoke-free public housing rule. It's something that HUD and tobacco control advocates have been working on for a number of years now, and thanks to all of those efforts, the rule was just finalized at the end of last year and is now effective, giving public housing agencies until July 30th, 2018 to implement smoke-free policies for the public housing they administer. So you've heard Kerry and Maya discuss nicotine addiction in homeless individuals and approaches to address tobacco use in temporary shelters, which on this housing continuum are represented on the left. We're now going to move along this continuum and talk about smoke-free public housing, which is one form of affordable rental housing. So why is it important to have smoke-free environments in public housing? Well, you've already heard about the disproportionate rates of tobacco use among those experiencing homelessness. And as those folks potentially transition to public housing, they, like many others living in public housing, are not exempt from the harms of secondhand smoke exposure. Almost 40% of public housing residents are children under the age of 18, and another 15% or so are over the age of 62. Children and older adults represent over half of public housing residents and are more susceptible to the harms of secondhand smoke. We also know that there are groups of people that disproportionately bear the burden of tobacco-related death and disease, and many of these populations live in public housing. If you haven't already seen it, HUD and CDC worked together and recently published this article in preventative medicine that reinforces the importance of reducing tobacco use among those living in HUD-assisted housing. This study is the first to describe different characteristics of residents living in HUD-assisted properties, including different associations of those characteristics with smoking status. So for example, a third of residents living in HUD-assisted housing smoked, half of those who smoked tried to quit in the past year, and those who smoked were more likely to report having a disability or some health condition like asthma or COPD. So that provides the public health backdrop for why HUD decided to require smoke-free public housing. This slide is a high-level overview of what HUD means by smoke-free public housing. First, the rule applies only to public housing owned and administered by public housing agencies, or PHAs. It does not yet cover other HUD-assisted properties like Section 8 or homeless shelters or supportive housing like Maya talked about. But I will say that the rule has sparked interest among all types of properties that are interested in going smoke-free. The HUD rule prohibits the use of conventional combustible tobacco products like cigarettes, cigars, and pipes, as well as hookahs or water pipes. And these prohibited tobacco products cannot be used in any indoor area or within 25 feet of any public housing agency building. There's also no grandfathering in the sense of exempting certain units, floors, or wings of a building, or of existing public housing agency policies that are not in compliance with the rule's minimum requirements. HUD has reinforced that its rule provides flexibility and discretion for individual PHAs to make determinations about their own policies. For example, deciding whether to include e-cigarettes and whether to have additional smoke-free outdoor areas. And they require PHAs to adopt these policies by amending their annual plans and their resident leases by July 30th of next year. So if you didn't catch all of that, please don't worry. We've created a handy one-pager that's available on our website that covers all of this information, and we will also have our slides available after the webinar as well. So PHAs now have to go through the process to either adopt an entirely new smoke-free policy or to make sure that their current policy is in line with HUD's rule. And the policy adoption process can be overwhelming. This is just one of the many resources out there to assist PHAs, and it's HUD's Changes in the Air Action Guide. While its focus is on HUD-assisted properties, I think it can also apply to smoke-free policies in other settings along the housing continuum, like shelters as well. It lays out these general steps, and you'll notice that there are more steps before you even get to implementing and enforcing the policy. What that tells me is that when it's possible, spending time on the front end of adopting a smoke-free policy can lead to a smoother implementation. And why is that? Because change is hard, and when you engage those that will be most affected by the policy change, both residents and staff, you hear their concerns and you do your best to address them. You bring them along with you as much as you can in the process. They're more bought in when it comes time to implement and enforce the policy, and it's not something that's being oppressed upon them, but something they had a say in and that more naturally leads to self-enforcing policies with higher compliance. I'm not saying that this means you won't have to enforce your policy, but when the approach and focus is on promoting compliance rather than punitive enforcement or overly punitive enforcement, it better aligns the goal of smoke-free policies, which is to provide clean, safe, and healthy air for all, with the goals of ending homelessness and keeping people in safe, affordable housing. So here's another way to think about the policy process and the many questions about enforcement of smoke-free housing policies that we get here at the Public Health Law Center. Working hard now, or early on in the policy adoption process, will hopefully pay off later when it comes time to implement and enforce your policy. Again, promote compliance by bringing folks along with you and setting a positive and encouraging tone in your communication about the policy. Make sure everyone is prepared and has been given enough notice about the policy change. Have a clearly written and communicated policy and think through ahead of time what your enforcement plan will be, including how you might handle reasonable accommodation requests should you need to use that plan. And here is just a bit more to elaborate on having a clear policy and thinking through potential compliance and enforcement issues. The policy should make clear that smoking is prohibited and is a violation of the lease that can lead to terminating residency. Of course, that's not the goal of smoke-free policies, but a rule without a consequence isn't typically very effective either. So it's important to have that last resort, but again, we would encourage that your enforcement steps focus on promoting compliance with the policy, and here are some ways to do that. Having a graduated or progressive enforcement process where you lay out what the consequence for a first violation, a second violation, on up to however many seems appropriate for the population you're working with, and being clear what sorts of evidence or documentation you'll use to show that a violation has occurred. Lastly, considering options for residents to remedy a violation, for example, attending a quitting class to erase a violation could also promote compliance. And at this point, some of you might be wondering, why give people so many bites at the apple, so to speak, to comply with the policy? I think this image does a really nice job of answering that question and can actually be interpreted in a few different ways. First, I think it's important to recognize that not everyone gets to choose where they live. We don't all have equal access to the same housing options, and so we provide additional foundations for people to reach those opportunities, which is depicted there on the right there under equity, or above equity. So in this context, I'll talk about next reasonable accommodations. We know that treating people with disabilities exactly the same as those without disabilities leads to unequal results. So here's another screenshot of a resource we just created on the topic of reasonable accommodations. Before I dive in, I want to spend just a minute providing some context. In the housing setting, our disability protection laws are meant to ensure equal access to fair housing. Housing providers are thus required to provide a reasonable accommodation when one is requested, if it's necessary to afford that person with a disability an equal opportunity. The accommodation might be a change to a practice, a policy, or a service. And before smoke-free housing was the norm, many reasonable accommodation requests came from non-smoking individuals with health conditions made worse by exposure to secondhand smoke. And they used reasonable accommodations as a way to gain access to smoke-free living environments. But as more and more housing providers have adopted smoke-free policies, what we've seen is a shift from requests to provide a smoke-free living environment to requests to accommodate or facilitate smoking behavior in some way. And that's what this new resource is meant to address. We provide responses to these types of questions that you see listed here, and we'll talk through these questions briefly now as well. So this is the general framework that fair housing law sets for determining how to assess reasonable accommodation requests. First, is there a disability that qualifies for protection under the law? And if so, is that accommodation necessary? Stated another way, is the accommodation requested related to the resident's disability in a way that without it, the resident would be denied a housing opportunity that residents without disabilities are afforded? And if so, that means the accommodation is necessary. But is the accommodation reasonable? If the answer is yes to these first three questions, a housing provider must grant that request. If it's not a reasonable request, though, housing providers are encouraged to work with residents to find other ways to help them comply with the policy. So now I'm going to just briefly walk through some potential responses to each of these questions, and I say potential responses because it's important to assess these individual requests on the case-by-case individual basis that they come in as. Again, the first question here to consider is whether the individual has a disability that qualifies for protection under the law. Generally speaking, smoking or nicotine addiction is not a qualifying disability. It is more likely that a person's underlying health condition, like a respiratory disease or behavioral health issue, would be considered a qualifying disability. If there is no qualifying disability, the request can be denied. If there is a qualifying disability, though, housing providers should then assess whether the requested accommodation is both necessary and reasonable. And here are some of the considerations to help decide whether a reasonable accommodation request is actually necessary. There are a number of myths about smoking as a coping strategy and inability to refrain from smoking that Kerry and Maya both talked about. And that can make answering this question very difficult. But smoking at this point is not a recommended treatment for any physical or mental condition. Individuals we know can abstain from smoking, and studies have also shown that quitting does not worsen certain conditions or increase the use of other substances. And finally, we also know there is no safe level of exposure to secondhand smoke. So assessing these considerations could lead a housing provider to deny a reasonable accommodation request because it is not necessary. If the requested accommodation is necessary, though, the request, again, must also be reasonable. And what sorts of accommodations are reasonable? Well, HUD, who is responsible for enforcing the federal fair housing law, has made it clear that allowing smoking in areas required to be smoke-free is not an accommodation that can be granted. That makes it easy then to provide a reason to deny a request to smoke inside a person's unit. But sometimes requests aren't to entirely permit indoor smoking, but to facilitate smoking behavior in some way. The reasonableness of these types of accommodations depends on the individual housing provider's administrative and financial capacity as well as operating policies, for example, what their smoke-free policy might say. So when a housing provider would be unreasonably burdened to grant the request, they may deny it. But denying requests can leave both residents and housing providers in a really difficult spot. So ensuring that residents are treated fairly and that they have equal access to safe, affordable housing is possible. And HUD actually encourages housing providers to engage in an interactive process with residents to help them find ways to comply with the policy if reasonable accommodation requests are denied. So some of the examples that HUD mentions are to move a resident to a first floor unit or closer to an elevator or door. I've also listed a couple of other examples here and think that this is where there's lots of opportunities to partner and find creative solutions. Because ultimately, we all want to ensure that people stay in their homes and that these homes provide a safe, clean, and healthy living environment for all. And so with that, I will turn it back over to Kerry.
Great, thank you, Darlene and Maya. Those were terrific presentations, just chock full of information. So we have time now for a few questions, so please feel free to send us your questions. We have a couple that have come in so far. Now this one, I believe we'll ask Maya to begin with, and it goes, providers taking care of homeless individuals often bring up the issue of tobacco being their last vice and the need for counseling against tobacco. Is there any evidence to support this viewpoint?
So it is an important thing that we've also seen in many of our studies where providers taking care of persons who are homeless refrain or feel afraid about asking about tobacco use because they feel that it's something that people it really is the last thing that they're holding on to that gives people joy. But the truth is that tobacco use is the leading preventable cause of death among homeless adults. And when you look at people above the age of 45, it not only is the leading cause of preventable death, when you look at substance use, tobacco use is attributable to about 50% of all substance use related deaths among homeless adults. So it is a significant contributor to morbidity and mortality. Taking that into consideration with what homeless adults think about their tobacco use, and we've seen in many studies now that interest in quitting smoking is very high among homeless adults, and you could even say that the quit attempt rate in some of the studies are about the same as among people who are not homeless. It's just that the successful cessation rates are much lower. So I would say that not bringing up tobacco use among persons who are homeless actually increases this disparity, and our role should be to try and address this every time we see them in clinic or in any other service setting, and also to increase our resources for smoking cessation for this population.
Thank you, Maya. Here I have another question, Darlene. Can you give an example of a reasonable accommodation related to the smoke-free ruling? Is there ever a time when someone could be allowed to smoke in their unit or would be allowed to smoke closer than 25 feet away from the door?
Sure. So in the context of HUD's smoke-free public housing rule and how public housing agencies can grant or deny reasonable accommodation requests, the question you asked about allowing smoking indoors or within 25 feet from the door does not seem like it would be allowed by HUD under a reasonable accommodation request. Again, they make clear in their materials that allowing smoking in smoking-restricted areas is not a reasonable accommodation that can be granted. And so I think what you're probably more interested in is the first part of your question about what sort of examples of reasonable accommodation requests could be granted under HUD's smoke-free public housing rule. And again, I think HUD does a great job of giving some examples of what those accommodations might be, such as, getting someone closer to a door to facilitate them getting outside beyond 25 feet. Maybe there is some sort of accommodation that's requested to understand the policy or help manage their cravings for nicotine and tobacco. Again, this is an area where it will really depend on the individual resident and what they request and what their where they are at in their tobacco use behavior, and what sort of resources the housing provider has and can partner with to find resources to help this resident comply with the policy.
Okay, thank you, Darlene. And I'll take the next question. You mentioned evidence-based tobacco control policies at state and local levels. Other than tobacco-free policies, what types of strategies would directly affect the homeless population? Well, price discounts and point-of-sale strategies target all consumers, but certain populations, including the low-income individuals, are particularly susceptible to these tactics. So looking at retail policies that prohibit tobacco product discounts, such as the multi-pack offers, coupons, those buy one, get one free offers that target price-sensitive individuals would be one way to address this financial incentive. And also, many low-income neighborhoods have more tobacco retailers and advertising than other neighborhoods, and many homeless shelters are located in urban areas where corner convenience stores, gas stations, and other retailers sell tobacco products that are hard to avoid. So looking at retail licensing options would be another type of tobacco control policy to consider. All right. So I've got another question, Darlene. There's been some confusion about whether the HUD rule is in effect or not. Can you clarify this, please?
Sure. So there was a regulatory freeze placed on some federal regulations, and it left discretion to individual agencies to implement that freeze. HUD has not, at this point, taken any actions to freeze their smoke-free public housing rule, and all indications point to the rule being effective February 3rd, and again, giving housing authorities until July 30th of 2018 to implement their policies.
Yeah, thanks, Darlene. Maya, here's a question for you, and I can follow up with a little bit more on this as well. It's a question about staff smoking, and the attendee wrote that the idea of staff smoking at these shelters seems to be a pretty big issue. What else is known about this?
So it is a big issue, and I think it's similar to what has been seen in other in other settings, such as residential substance use recovery programs, where staff smoking can be seen as, in particular, staff smoking with clients can be seen as a way to build therapeutic alliance. We actually did see some staff reporting those behaviors with clients in shelters as a way to build alliance, establish rapport, and we found that those kinds of behaviors actually don't really provide an environment that would support smoking cessation or changes in smoking behaviors. So our recommendations actually did involve either having separate designated smoking zones between staff and clients, and many shelters actually had written policies in place that supported that, and that staff, that any cessation program in shelters also included cessation counseling and treatment for staff involved with clients. I don't know if that answers your question, but that's what we found in our research.
Thank you. And our organization was recently awarded a research grant from Clearway, Minnesota to study this issue, so we'll be following up and looking at the types of effective interventions that shelter administrators can consider to help both staff and residents with nicotine addiction. Okay, we have a few more questions here. Have you found that increasing the cost of tobacco products makes the homeless more likely to snipe cigarettes and vandalize butt receptacles? That seemed to be the effect in my community. Maya, is there anything that you've looked into at all?
Yeah, I can talk a little bit. So we just actually did some work on looking at cigarette purchasing, and basically found that it accounted for about a third of people's income. I don't have any recent data to suggest that increasing the price of these products makes people more likely to snipe cigarettes or use or vandalize butt receptacles. But I think what we are finding, because San Francisco just increased its cigarette price by $2, and we're comparing practices prior to this increase to after the increase, and so far we haven't really seen people use any other forms of tobacco or more risky forms of tobacco behaviors in response to the price increase, but I think this is yet to be determined.
Thank you, Maya. And the attendee followed up with a comment. The local homeless shelter gives, her local homeless shelter gives grocery store gift cards in exchange for working on litter pickup. These cards are used to purchase tobacco products, which makes the residents less likely to snipe and less likely to beg cigarettes off passersby. And also, this person responded that the tax in her community is $5 per pack. Sounds interesting. Well, we only have a minute left, so I'm going to take this opportunity to thank our speakers, Dr. Maya Vijayaraghavan and Darlene Wong, and to encourage you to visit our website at publichealthlawcenter.org for additional information about tobacco use in the homeless population and other vulnerable priority groups, as well as smoke-free housing and public housing issues and tobacco-related issues in general. Thank you all again very much for attending our webinar.